Today on this episode of The Brain Surgeon's Take, we will be discussing improving health equity in the USA with Chief Health Equity Officer and co-director of the Translational Science Institute at the University of Miami, Dr. Erin Kobetz. Learn how access to medical care is disparate across this country, leading to higher risk populations, and what we can all do to even the playing field for Americans, regardless of race, gender, and socioeconomic status. Much more on this podcast episode. Welcome back, everyone. Here's my take on Dr. Erin Kobetz. She clearly has a vision for what healthcare should be in this country and is dedicated to getting us there. As Chief Health Equity Officer at the University of Miami, Dr. Kobetz understands the inequalities that exist regarding access to medical attention, especially as it relates to gender, race, and socioeconomic status. Although we are one of the richest countries in the world, unfortunately, our healthcare system does not cover Americans equally. There is no perfect system, and we all know that, but we can always strive to have a more uniform standard of excellence for our nation's healthcare. What I loved most about this interview was Erin's drive and passion for the field. Healthcare is a right, and while the situation will never be ideal, we must strive to address the glaring inequities that currently exist in this country. The solutions are complex, involving local, regional, and national governments. But with Dr. Kobetz leading the way, our future looks bright. Listen up as we discuss improving health equity in the USA. Check it out. Hey, Erin, how are you?
I'm good. How are you?
Good. It's great to talk to you today about such an important topic about healthcare inequities in the USA.
I'm happy to talk to you about it and to see what we can do when we put our collective brains together to maybe generate some solutions for change.
Absolutely. As we're going to talk about, this is the richest country in the world and so many healthcare resources, but the question is how to allocate it more appropriately so that everyone has access to high quality healthcare. And I am very interested to see your thoughts on what we can do locally, regionally, and then nationally to help make that reality. I guess let's start out with the obvious question. How did you in particular get interested in this field?
I was actually thinking about this because I thought you might ask me how I ended up doing healthcare disparities work. So I think there are two seminal moments like in my life that helped me recognize that I wanted to do research that would be a vehicle for social justice. So the one was when I was a Ph.D. student. I was working in Eastern North Carolina with rural African-American women who had really limited access to the formal healthcare system. And there I came to appreciate the gap, right, between their lived experience and mine, and how if I wanted to really affect change, that I was going to recognize how most of the truth for accelerating solutions for health equity would have to come from the people whose lives were characterized by disparity. And it was very eye-opening for me, to spend time with women who had this limited formal education, but could articulate quite eloquently like why they were skeptical of the healthcare system and why they had real concerns actualizing recommendations made by physicians who are predominantly white, who they didn't think understood by any stretch of imagination their lived experience, or how when they walked into a mammography facility that there were judgments being made about them on the basis of their race. So that was a very foundational experience. When I was recruited to sorry, did you want to say something?
No, I'm sorry, go on.
So when I was recruited to the School of Medicine, which is almost 20 years ago, which dates me pretty tremendously.
That's crazy.
I was recruited straight out of my PhD by Jerry Goodwin, who was the then Cancer Center director, who wanted to develop a program in cancer disparities and thought me, with my very limited formal academic experience, would be the right person to do it. I was hired as a social epidemiologist who was going to look at big data and to examine trends in cancer outcomes that may help us better identify which population subgroups were contributing to excess disease incidence and mortality. And then I get diagnosed with cancer. And all of a sudden, this idea of me studying statistics feels irrelevant when I become one. And so felt strongly, because of my medical capital, that like if I walked away from my diagnosis with very little disability, that I had an obligation to pay it forward in a real way. And I remember, moving from like diagnosis to surgery within a couple of weeks. And still, those weeks were riddled by unbelievably immobilizing anxiety. And then I thought, well, what if I was a woman who lived in Little Haiti, who finds a lump in my breast, and I'm waiting 9 months to get a
Mm.
diagnostic mammogram? And that 9 months, not only is it affecting like my ability to function, but it changes the course of my disease. And so, it's like one of those things, like sometimes something that is really painful becomes your purpose and your power. And that experience for me is definitively like when I decided that health equity was where I was going to orient and organize my career.
That's such a classic story when someone undergoes adversity and turns that into a positive. Not everyone does that. It actually takes a very special person to do that, but that's ideally what you do, right? You have a challenge, some adversity, you learn from it and you give forward like you were saying. And that's incredible how you turned a negative into a huge positive for so many people. And we'll talk about, healthcare disparities can exist based on gender, race, social economic status, like you said. Do all three interplay, or is one more powerful than the other, in your opinion?
I think they all interplay. Um, and what's really interesting, and I hope we spend some time talking about this, is that later in my career, I started working with firefighters who were at increased risk of developing and dying of cancer. And these are individuals who not only have access to the healthcare system, they're part of it. And so then you're talking about disparity from a totally different lens than we traditionally conceptualize. And I have to tell you that working with the firefighters really challenged some of my own assumptions about how we characterize disparities, so that it's not limited to just race, ethnicity, but it appreciates the complexity of these multi-level determinants that are driving inequity across multiple levels of effect for different populations.
So you just mentioned those forces that are driving those inequities. What are the major forces driving those inequities?
So I think it's actually really context specific. So I can talk a little bit about my work in Little Haiti, which is where I stumbled after my cancer diagnosis, after doing a mapping exercise that identified 4 times higher incidence of cervical cancer in Little Haiti relative to other ethnic enclaves throughout Florida and the United States. I think if you talk about Little Haiti, and we'll talk about Little Haiti today, not 20 years ago. So, one, I think that many Haitian immigrants face this double edged sword of being both Haitian or Black and non English or Spanish speaking. So, there is racial and linguistic barriers at play. Little Haiti, despite being geographically proximal to our medical school campus, is a federally designated medically underserved area, which means that there are a shortage of providers available to meet the preventive care needs of the community. So not only are people not getting access to primary care, their ability to participate in specialized care is even more difficult, because where do you begin, right? So access is a big impediment. I think that there are like pluralistic understandings of health and disease prevention that those of us in medicine often take for granted. I think we buy into this notion of like germ theory, for lack of a better word, as like a single truth. And I think in many of the communities I've worked with, I've come to recognize that yes, people recognize that germ theory is important, but they also use these lay interpretations of disease etiology to inform both their understanding of the significance of a disease like cervical cancer and whether something like pap smear screening makes sense, right? Like I make these recommendations, like your 21 years of age and older, you're sexually active, you should have cervical cancer screening, without realizing that like that doesn't land exactly the same way for all women. There were lots of behavioral practices that we had to unpack and appreciate. So women tended to engage in like a vaginal drying exercise because there was a cultural preference for dry vaginas. And by doing routine douches, even with natural products, you are changing the microbiome of the vagina in such a way that it's more susceptible to human papillomavirus, which is the principal cause of cervical cancer. So it's not one thing, right? Like, and I'm sure what I'm describing here is just the tip of an iceberg that, like, if we were to continue to dig, we would understand that there's an inherent complexity in why health disparities are catalyzed and sustained.
Makes sense. I would also ask you the kind of $1 million question, which is, and it may be tough to address, but how much of a role does the structural racism that exists in this country, and it definitely exists, how much of a role does that play in healthcare inequities?
I think it plays a significant role. And one of our colleagues, Neha Goel, who's a breast surgical oncologist, has done some really important research actually quantifying, right, the influence of structural racism, both on stage of disease, a diagnosis for breast cancer, and also in variability of breast cancer histologic types. So that women who live in areas that are characterized by structural racism and deprivation have greater likelihood of being diagnosed with a triple negative breast cancer, which we know doesn't respond as readily to available treatments. I think it is this like complex interplay of like structural racism and class, right? Like in other countries, I think that disparity is better appreciated along a socioeconomic strata or hierarchy. I think in this country, it gets very complicated because racial ethnic minorities are overwhelmingly at the lower end of the socioeconomic hierarchy, and that's not coincidence. And if you go back to that story I was telling you about Eastern North Carolina, racism or perceived and structural racism was really at the heart of why the women that I worked with and the women that they served were being diagnosed with late stage breast cancer. They didn't have the same access to mammography. They didn't feel comfortable getting mammograms. And there had been this historical disenfranchisement of African American women from the healthcare system in such a way that it was no longer really a barrier, it was a truth.
Now, people may ask, why is it so important to address healthcare inequities in this country? Obviously, there's the ethical issues, right? Everyone deserves to have quality care. But more so, how does it affect our nation negatively if we don't have adequate healthcare for everyone?
So I'm asked that a lot. And the truth is that countries or communities that are more equitable in terms of healthcare outcomes, everybody is healthier, like including those who are at the tippy top. So, for me, it is primarily an ethical issue. It's a moral issue. I believe that health equity is somewhat of like a basic human right. And then it's, this obligation that we have as human beings to buy into this collective good and to be the tide that rises all ships. Because if you make a little difference in disparity, it has a really big impact, not only for the community that's characterized by disparity, but all of us.
How does Miami compare to the rest of the country? Are we more or less inequitable?
So Miami is an interesting context, and you know this, right? Because we are characterized by unbelievable, unique multicultural diversity that allows us to start to conceptualize disparities, I think, in a very different way than elsewhere. Like, we don't just think about Black-white differences in health outcomes. We also think about within group differences. So within our Black community, within our Hispanic community, we often see a lot of variability in terms of the contribution to disparities, right? Bahamian women are not the same as Haitian women, who are not the same as African American women, who are not the same as women from the continent of Africa. And so I don't know that you can say Miami is better or worse than other places, but Miami provides a really unique context by which to reconceptualize disparities and to identify within group variability that may allow us to get closer to understanding the etiology and to generate the solutions to change it.
Now, you've done some amazing work locally and regionally to address a lot of these issues. On a more national level, what important initiatives are being worked on at a federal level?
So, federally, like the Moonshot Initiative just gave a ton of attention to women's health, right? There's a women's health initiative, a recognition that gender is, if you will, a way to characterize disparity, and that the health of men and women is not necessarily equal. And for health conditions for which women and men both experience, that sometimes women's outcomes are worse. There's been a lot of attention in the National Institutes of Health and the different branches, including the National Cancer Institute, around trying to understand the multi-level risk factors and conditions that drive inequity in health outcomes. There are a number of funding announcements looking at the biologic basis for health disparity. Even the NCI designated cancer centers, of which Sylvester is one, actually have an obligation through our funding to try to be an agent for health equity within the catchment areas that we serve. And we are obligated by our funding to work collaboratively with diverse community stakeholders to both pursue mutually beneficial science and to ensure that our research maps onto their priorities. And I think it's like this campus community collaboration that ultimately lends itself to having science generate interventions and solutions that may get closer to health equity.
Now, COVID really exposed a lot of limitations in this country. And I think healthcare inequity is one of them. Just tell us what role COVID played in bringing those inequities to the forefront and making sure that we address them.
So like I think for someone like me who's spent now 20 plus years working in health inequities or health disparity, what we saw with COVID wasn't a surprise, right? It wasn't like a if, it was a when. And I think what COVID did was raise collective consciousness about the fact that health is not experienced equally and that there are marginalized groups of individuals in this country who have worse outcomes, and that we cannot all be optimally healthy unless we address those outcomes. And COVID became like a nice case study because it was infectious, right? I think when you're talking about chronic conditions, it's very easy to point the finger and to say, well, this community engages in a lot of smoking, and therefore we appreciate they have higher lung cancer risk. But with COVID, when you had communities that were really experiencing a disproportionate burden of new infection and death, it made all of us sort of tap into our respective vulnerability, because you never knew when you could have been exposed to somebody from that community. And so I think it sort of cast like a binocular, I think that's the right term, like a light on the fact that things are not equal. And there was, I think, a lot of outcry broadly about the inequity. I think the timing with the murder of George Floyd, showed that these are complicated issues that are not just about personal or community susceptibility to disease, that there are these higher level forces that condition certain communities to be vulnerable both to violence and poor health. And I just hope as we get further away from COVID that we don't lose that shared awareness that we have an obligation to do something. Because there was this immediate, big organizations, big companies were putting aside lots of money for health equity. Now, what they did with that and whether it's moved the dial, I think remains to be seen.
Well, it's only a matter of time before the next pandemic. Obviously, it's not if, it's when. And so Yeah, if we haven't addressed those permanently, we're going to be in for another rough go on the next pandemic. Let's get into another controversial topic. Will the overturning of Roe v. Wade exacerbate what is already a large racial disparity in maternal and infant health?
So, there was actually a story in the New York Times about this yesterday. I'm not sure if you saw that. I think that they've shown in places where women no longer have access to reproductive care that infant mortality continues to rise. And obviously, we know that this is a scourge, particularly for communities of color who contribute to excess infant and maternal mortality because of lack of access to primary care, lack of appropriate social support for pregnancy and childcare. I think the empirical evidence is there. So I'm not even sure it's so controversial. I think what's controversial is that a woman's health issue has become unfortunately politicized, and you have physicians, right, who are now in the decision or are now in this awkward situation of having to make decisions about whether to break the law or to uphold the Hippocratic Oath.
Mm,
And
brutal.
so, sometimes when these laws get passed, not sometimes, they all the time, they disproportionately affect those who have less political capital, less economic mobility, and less voice.
Yeah, I think it's kind of a downward spiral like you're talking about. I think the more we put the power with the politicians and not with the physicians taking care of patients, the worse off it is for the mothers and the children. Um,
I
Now
mean,
let's
think
talk.
about the HPV vaccine, Rick,
Yeah,
right?
same
Like,
thing.
here's a vaccine that, like, I mean, you can prevent cancer, and it's not just cervical cancer. It's like 6 or 7 other types of HPV-associated malignancies. But because of the rollout and because it was linked with a sexually transmitted infection, which all of us probably will have at some point in our life, people are unduly skeptical about the vaccine and worry that giving it to their child might in some way promote sexual promiscuity. So we're making politicized decisions about public health. And when public health and medicine become politicized, we are going down, I think, of a very sort of scary rabbit hole where science and empirical evidence no longer have the weight that they should in driving decision making.
This is a topic for a whole nother podcast, but yeah, I mean, COVID and the vaccine and just how science has taken a backseat to politics is kind of crazy in healthcare. But I won't get into that because it's so controversial. Um, what do you think what do you think about the current mental health crisis in this country, which is, I feel like, skyrocketing, and how has that impacted healthcare inequities?
So, actually, when we do our community health needs assessment for the health system, which is a requirement for all not for profit health systems, the number one issue that's raised by diverse community stakeholders in South Florida is mental health and lack of access to mental health care. And, I think it's a very complicated topic for which I'm really not an expert. I will underscore, though, that when there's an emerging public health crisis like mental health, that's not experienced equally by the population at large. In the same way that the benefits are not reaped equally by the population at large. And so if we take our eye off health disparity, we miss the opportunity to really help those individuals who are most susceptible to the worst outcomes for something like mental health, for COVID, for cancer, right? I
What
mean,
ab-
think about it. You're a brain surgeon. I am sure that you treat individuals who, had they seen you 6 months earlier, that the outcome would have been entirely different,
for sure.
both in terms of their morbidity and in terms of their mortality. And this inherently is an issue of health disparity that, like, we've now put on the individual level.
Yeah, and I think, yes, we need to provide more access. There does need to be some patient responsibility, even for the people who have access, right? A lot of times people will just be in denial. They don't want to go to the doctor because they don't want to
Mhm.
get bad news, or they get bad news and they're given a treatment plan and they don't follow it again because of denial. And so again,
Or social determinants of health, right? So I agree. Like, if I go back to my story in Little Haiti, so women didn't have access to cervical cancer screening. Those who did had major barriers around the traditional physician-based speculum exam, because they felt that when the speculum was introduced into their vagina, it would change its tone or rigidity in such a way that they would no longer be sexually desirable to their male partners on whom they're economically dependent. So, yeah, there's some responsibility, and yeah, it's really, really complicated. Then you get maybe somebody who has an abnormality and needs to follow up, but is worried about the implications of follow up, doesn't really have appropriate education about the necessity and timeliness of follow up. Or the thing that like kills me, and I try to train our medical school students to think about things from this sociological framework, is like you meet somebody who is a type 2 diabetic, and your recommendation is what? Eat healthy and exercise. Okay, well, they live in Liberty City and it's a food desert. And like exercise outside is questionable given gun violence. So you've now just made a recommendation for somebody to adhere to a treatment plan that they can't, because there are all of these other extenuating factors, including social determinants, that constrain their ability to practice health behaviors that are health promoting, even if that's their intent.
what would you say? We've talked about Miami, we've talked about the US. Globally, in your opinion, your experience, what countries have the least healthcare disparity?
So I think the countries that have the least health care disparity are places like Sweden, right, where there's not huge gaps between different groups of people, right? Like huge gaps in terms of socioeconomic position, access to healthcare, exposure to environmental toxins, social determinants of health, where there's more equality that conditions better equity. I think that's changing though.
How much of that is due to the fact that that population is so homogenous, right? Like the diversity in the US is like a million times more than it is in Sweden.
So it's hard to know, right? So I think a lot of it is about the homogeneity of the population. And then I think a lot of it is about the different social supports that are in place to ensure that all individuals can be optimally healthy, regardless, right, of their individual propensity for disease. But you're right, in a place like the United States, which is incredibly heterogeneous or heterogeneous, and people come, to this country with different perspectives on healthcare and health, and are exposed differently to social determinants and to environmental um, exposures. It's really hard to come up with a one size fits all. And so it requires all of us really working in a localized fashion to learn lessons as we implement solutions that can translate to other contexts.
Now let's put you in charge of US healthcare. Let's just say, all right, you're in charge of US healthcare. Give us the top 3 changes you would make.
I mean, I'm worried about answering this in case I want to run for office. Like if somebody like chases down this podcast in a couple of years, it could really affect my candidacy.
Well, you can answer it kind of vaguely if you wanted to.
So I think that we probably need to put more emphasis on prevention, right? Like I think prevention has been shown time and again to be a better investment than cure. And so how we operationalize prevention, how we provide equitable access to prevention, I think requires people thinking strategically and innovatively, and really requires, I think, multi-sector collaboration. I don't think it's something that like we in healthcare are going to solve on our own. So prevention is one. I think
Let me ask you just one, let me interject. let me just play devil's advocate. I would say the reason why that's very difficult, not impossible, is financially. The money's in cure, it's not in prevention. And
Right?
so
So, but you said I was gonna be in charge.
yeah, that's true. That's true. So keep
So if
going.
I'm in
I just
charge, I thought I think you have to start to shift the paradigm, and I
yeah,
think we have to really have
incentivize. You got to
payers and
incentivize.
physicians incentivized in such a way that it becomes more approachable and there's not as much disincentive because of how much is allocated in terms of the financial benefit to cure, right? So you said I was in charge, so I'm dreaming big.
Okay.
Um, I think that we need to like really sort of think about we need better data collection, much better
Yeah.
data collection. There's only a couple of registries. Cancer is obviously a disease for which incidence and mortality are tracked. But even then, like there, we have a long way to go, right? So you and I could go look today to think about incidence of glioblastoma in Black men and women in South Florida. But if you wanted to know things about behaviors, or you wanted to know things about genetic risk factors, or you wanted to even know things about the genomics of the tumor, we'd be hard pressed to have any of that information. And so I think until we have more robust surveillance systems and we really deploy machine learning and AI in practical ways that informs our understanding, we get further and further away from this concept of precision medicine, which really needs to happen on a population level. Is that fair? Are those like
Yeah.
good,
Uh,
like, are you
Well,
ready to vote for me?
that was 2 out of 3. What's
Oh,
the
three.
yeah, what's the third change you would make? And I'm gonna hold you to this so that one day when you're running the country, we're gonna go back to this podcast and I'm gonna say, look at what Dr. Kobetz said.
Um, I think so something I'm working on right now, like within our health system, is making sure that we know the social determinants to which different patients are exposed, right? Like you just do this complicated brain surgery on someone and you have no idea that they're going home to a place without clean water. Well, now we have a problem because their ability to reduce the risk of infection and unnecessary readmission is challenged. So that's something. I think we need to pay more attention to things that are non-clinical but definitely affect clinical presentation. And I think that we need to build community capacity to really deal with health in communities as opposed to emergency rooms. Um, so we'll see. I'm not sure how we actualize that, but there are too many instances of people showing up to emergency rooms for issues that are non-urgent or emergent. And we have to have community infrastructure to provide individuals access to the care that they need to manage their concern so that emergency rooms stay the places for emergent situations that demand really high level sophisticated care, not I can't refill my medication. So
Listen,
those are
Erin,
three.
yeah, I mean, those are 3, and those, if we could implement those tomorrow, that'd be amazing. But like we talked about, there's so many barriers infrastructure wise that it's going to take time. It's going to take people like you who have devoted their career to it, which is amazing. And I want to say thank you for being on the podcast. I think that, for me at least, take home points are that you are tackling the most difficult part of medicine, I believe, in the sense that there's no perfect answer. And you look at the USA, we have all this money in terms of high end healthcare, neurosurgery, cardiac surgery. We have the best in the world, but the disparities are just, you can't even begin to kind of close the gap right now because there's so many issues. And so it takes people like you devoting their entire career to it. And hopefully we see change. I mean, I've definitely noticed a change here in Miami due to your help. Um, and I'm excited to see what you and your colleagues do moving forward.
Well, it takes a village, and I'm honored that you're part of mine. And It's been great to be on the podcast and to get to spend some focused time with you. I feel like most of our exchanges are by quick text.
Yep.
So, thank you for also pushing me to think hard about what I do and why I do it, and to remind me that, like, this is my purpose, and that purpose um, is really important for like my personal satisfaction.
Well, it's your legacy. And if you think about why people become a doctor, either medical or a PhD like yourself, it's to make a difference, right? So I help 4 people a day. Your work is helping thousands, hundreds of thousands, and potentially millions of people. And so I think the spectrum of your work should never be lost in the sense that the changes you make are not individual families, it's entire communities. And that's a major responsibility you have.
Thank you. But the Talmud would say, if you save a life, you save a world. So we're in this together. And I mean, I do. I feel like it is a privilege to get to do this work, and hope that I continue to pay forward the commitment that I made to myself almost 20 years ago when I decided, now that I'm a statistic, I have an obligation to change them.
Erin, you're amazing. Thank you so much for joining us. And I'm sure I'll talk to you soon.
Thank you.
Take care.